So when thinking about a disorder involving erythrocytes, you need to think about the function of an erythrocyte. So how would a disorder affecting the erythrocyte or red blood cell would express itself? Right? And so as we're going through this lecture, you should be thinking about really the functions, okay, of the structure that is normally present, and then what would happen if we start to alter it a little bit. So the first topic that we're going to really get over regarding erythrocytes is anemia. Okay, and anemia is a decreased carrying capacity of oxygen. And so if they have you think of the normal function of a red blood cell, its normal function is to transport oxygen efficiently throughout the body. Okay. So we would use these two clinical measurements here to diagnose anemia. And then we would need further testing to get into the subtypes of anemia, which we're going to talk about in this audio lecture. So hematocrit less than 41%, and if you recall, hematocrit is the packed cell portion of a blood sample, right? So if you take a 3 cc sample, red blood cells are going to separate out, leaving plasma on top because the red blood cells are more dense than plasma, and they're naturally going to separate, but we could use a centrifuge to separate them faster. So that can be one clinical definition. Another definition is hemoglobin concentration. So hemoglobin is actually what is transporting the oxygen, and we see that red blood cells or erythrocytes are filled up with hemoglobin. And so a measurement of 13.5 grams per deciliter or less would be a definition fitting anemia. Okay, this anemia can really originate from multiple sources. We could decrease the red blood cells. Okay. We could decrease the hemoglobin. And last but not least, we could produce abnormal hemoglobin, right? So the last couple of examples that we're going to see today, we see abnormal hemoglobin actually produced. Okay. What are the manifestations general to anemia? Okay. So whenever you think of anemia, first and foremost, you're going to be thinking a decrease in oxygen transport, which is going to leave the body in a state that is difficult to produce ATP. So weakness and fatigue are going to be symptoms or manifestations, and then you wouldn't see the normal red appearance due to the hemoglobin because now we decrease the amount of hemoglobin, resulting in pallor, which again is a ghost-like or pale appearance to the skin. Okay. Now, some other manifestations of anemia are more directly related to brain delivery of oxygen to the brain. Okay, then if you don't get enough oxygen to the brain decides it's going to shut down. It's going to put us in a life-saving mode. Okay, and this is called syncope, right? So fainting is syncope. Okay. These two go with getting oxygen onto our cells. So now the cardiovascular centers and the respiratory centers in the brain are determining that we don't have enough oxygen, right? So they're going to try to increase this by increasing breathing and then increasing the cardiovascular system, right? So dyspnea can be labored breathing. That's what its definition is. And it's labored breathing because you're breathing and it's not effectively doing the job it's supposed to. So it's not loading up erythrocytes or hemoglobin more specifically with oxygen. Okay. Now for tachycardia, really the only way, so we could breathe more, we could breathe deeper, okay, but the only way we're going to expose more red blood cells to the oxygen, okay, is put them through the lungs at a faster rate or a higher rate, okay, and this is going to result in tachycardia, which is increased heart rate, right? So anytime you have, so a nice example of this is when you stand up too quick, right? So in your baroreceptors that detects pressure going up to your head are stimulated. Well, their job is to make sure your brain has plenty of blood flow, and so the increased gravity would decrease the pressure going to the brain, okay, And then so your heart's response to this is going to increase rate to increase blood pressure, okay? Increasing delivery of oxygen to the brain. This is the same example, so it's just not standing up in anemia, it's just less oxygen is getting delivered to the brain on a regular basis. Next up, we have more mean corpuscular volume. So this is going to be the volume of space that a red blood cell occupies, right? And so this is actually a diagnostic technique. And so you see we have various levels of this mean corpuscular volume. A measure you could also get probably while doing this is mean corpuscular hemoglobin concentration, or MCHC. Mean corpuscular hemoglobin concentration tells you about the hemoglobin content inside of the corpuscle, which is just a blood cell. Okay, so a red blood cell is a corpuscle, so is a white blood cell, so technically a platelet is not even a cell. But those are mean corpuscular. They would fit under this definition of mean corpuscular volume. Right? So depending on the type, it would dictate really what kind of anemia we have. And so we see a few different kinds of anemia. We have iron deficiency, thalassemia, which we'll talk about. These two, we have aplastic and hemolytic. Okay, we'll talk about them. And then we have pernicious anemia as well. And so we see that each one of these kind of has this characteristic mean corpuscular volume. Okay. Again, it's going to be the volume that a red blood cell occupies, and you would get this by measuring the blood volume, which is not as straightforward as it sounds. Multiply that by that hematocrit, and then divide it by the red blood cells in the blood sample. Okay, so you would send this through a cell counter to tell you how many cells are actually in there. You could take these two measurements manually. So getting on into the different types of anemia. So iron deficiency anemia is going to manifest itself in the same manifestations that we see with general anemia: weakness, fatigue, pallor, syncope, dyspnea, tachycardia. And really what iron deficiency anemia is you don't have enough iron in your diet, or you're not absorbing it at a high enough rate. And so we see that, remember that in order for hemoglobin to do their job, they need plenty of iron. Iron is what binds the oxygen and transports it around your body, right? And so if we don't have enough iron to meet the requirements for the hemoglobin of the erythrocytes, then this can lead to anemia. Okay? Decreased iron consumption can be one. Decreased iron absorption in the gut can be another mechanism. And then we see individuals with iron deficient anemia also have increased bleeding, which is a function of platelets, not erythrocytes. Now, this is a particularly important one because we already only absorb 10% of our dietary iron, and so we don't have much room for air, right? So we have to make sure we get this in our body. So this iron deficiency anemia is going to be pretty common in sexually mature women with a regular menstrual cycle, okay, children less than 2, and then elderly individuals. Why menstruating women? They're losing a fair amount of blood every single month, and so they have to, in turn, produce new hemoglobin and new red blood cells every single month, and they have to have enough iron there to be able to make sure that it's possible. Children less than 2, this is a really common problem. They usually just have a difficult, they have too little iron in their diet to fulfill the needs. And so my son was on an iron supplement for a while because he was fairly anemic, not terrible. And then elderly individuals. And this just has to do with things slowing down as you get older, and really processes not going as well as they planned as you get older as well. So how is iron deficiency anemia going to manifest itself? Typically, anytime you have a low oxygenation state, so since we have less hemoglobin circulating in our body, the tissues are really going to suck it off pretty quick, and so this might give the blue tinge to our skin, known as cyanosis. Brittle nails. So kind of goes with the same function here. So we're transporting less oxygen. We have less capacity to produce ATP. We have less ATP for building materials. And so this would go for proteins too. Remember that your fingernails are a protein, mainly keratin. Okay? But anytime you're building something, it's going to have the decrease in structural integrity under anemia. Decreased appetite can be a concern, headache, irritability. All three of these things kind of go together. So decreased appetite would give me a headache because now I'm not consuming enough food, and then I would be irritable because I'm hangry. Stomatitis. Stomatitis is inflammation of the mouth or lips. Food cravings to kind of counter the decreased appetite, and last but not least, delayed healing. Right. So if you aren't carrying around as much oxygen, you don't have as much ATP to produce the necessary components for healing. So how would you diagnose iron deficiency anemia? You're going to do a complete blood count, which is going to give you measures of red blood cells. It's going to say how many leukocytes there are in circulation, how many platelets. Okay, but it's also going to give you information about the corpuscular volume. So we see that mean corpuscular volume in iron deficiency anemia is low, and so this means you have a small blood cell for the typical selection of blood that you would take, and so we see that it fits under this category over here, under the low category. Serum ferritin. So ferritin is responsible for absorbing iron in the gut, but it's also involved in moving it around the body. And so once it's moving around the body, it's known as transferrin. And so we would get, with these blood samples, we would get serum iron, serum ferritin, which is responsible for carrying the iron, or absorbing it in the stomach, and then it's converted into transferrin, which there's a slight typo in your book, it says transferrin. So transferrin saturation, meaning how many of those transferrin proteins that we have in circulation are actually, they have an iron bound to them. Okay. So we're going to be looking at all this stuff to complete a big picture. So how are you going to treat iron deficiency anemia? Well, the first thing to do is going to be increasing iron-containing foods. So your dark leafy greens, your meat products, if you eat meat. Okay. One thing is make sure to concurrently take in vitamin C. So a well-balanced meal would provide this for you. You're going to want to make sure that it has B12 in it. We're going to come to the importance of that in a couple of seconds. One thing would be iron supplementation. So when my son was diagnosed with iron deficiency anemia, they put him on an iron supplement. And so the weird thing is my son liked the taste of pennies, which that's what iron tastes like, and he would get excited about taking his medicine. Those days are over now, though. So pernicious anemia is going to differ a little bit from iron deficiency anemia. So pernicious anemia is due to the deficiency of vitamin B12. Vitamin B12 is heavily involved with cell division and DNA synthesis, and so its deficiency results in a decrease in red blood cells circulating. Okay. This all stems from a lack of intrinsic factor production. Intrinsic factor is what allows absorption of B12 to occur. Okay. Like I said, B12 is involved in DNA synthesis. Okay. If you don't produce the intrinsic factor, then it's very difficult to absorb B12. And so what we get here is you get decreased absorption of the iron because you see changes on the gastric epithelium and then also changes in DNA synthesis. And so the thickness of the gastric epithelium is going to decrease, and that would negatively affect iron absorption. And then you're going to suffer from neurological disorders, and that's specifically myelin sheaths on neurons will end up breaking down. So what are the manifestations of pernicious anemia? Bleeding gums, diarrhea, impaired sense of smell, and anorexia. Now, some additional changes can occur, such as personality changes. Now, this would be a test. Okay, a test. This is a diagnostic test, so this is called the Babinski test. And Babinski test is when you have maybe a pin and you rub the pin down the foot, and so normally the response is bending of toes. In this case, we get splaying of the toes, so instead of curving down, they go outwards and they go up. Okay. And that's a positive Babinski test right there. Okay. Again, you're going to see stomatitis, which again is inflammation of the lips or mouth, and then paresthesia of the hands or feet, which is going to be numbness and tingling of the feet. How are you going to diagnose pernicious anemia? Well, you're going to do a complete blood count. You'll look at the serum B12. Next, we would do a Schilling test, and the Schilling test is going to be a diagnostic procedure for those who suspect they might have pernicious anemia. And so this is essentially looking at absorption of vitamin B12. Gastric analysis. And then bone marrow biopsies. Okay. This bone marrow biopsies is pretty much always going to tell you what the condition is, but that's a fairly invasive procedure. Right? So if we look at the mean corpuscular volume that you would get from your CBC, you would go over here to high, and then you see that pernicious anemia is located over here. So that means that we have a high volume taken up by our B12 or by our red blood. How are you going to treat pernicious anemia? B12 injections. Okay. So this would work to counteract the lack of B12 absorption because it's going straight into circulation, and now B12 can have its effects. Okay. If you are producing enough intrinsic factor, oral B12 is administered. Okay. But these B12 injections would kind of circumvent the digestive system. So what is aplastic anemia? Aplastic anemia is going to be considered pancytopenia, right? So now all of our blood cells are lowered, right? So leukocytes, erythrocytes, and platelets. Okay. This can create a whole slew of problems, right? So we would see problems with fighting off infections, bleeding, and then our blood is not going to be able to carry enough oxygen, so hypoxia. Right? This isn't necessarily a permanent procedure. Oftentimes it is temporary. So what causes aplastic anemia? Sometimes it's just spontaneous, such as idiopathic causes. It has autoimmune disorders, so if you have autoimmunity, the antibodies can attack your myeloid stem cell precursors, medication and treatments like radiation therapy and chemotherapy. You remember, they're not going to be specifically targeted towards any one thing. Viruses, toxins, genetic abnormalities. So if you're born with a genetic disorder affecting the myeloid cells, okay, we're going to see really alterations to erythrocytes, to leukocytes, and to platelets. Okay. Infectious disease, pregnancy, cancer. Now, if it occurs during pregnancy, it generally goes away after the pregnancy is over. So how is aplastic anemia going to manifest itself? it's going to be the same exact symptoms of general anemia, except it's going to add in a few more, right? Specifically talking about leukocytopenia, so a decrease in white blood cells, you might be susceptible towards infections, or thrombocytopenia, you might have difficult clotting blood. Okay? If you don't treat the manifestations, they do generally get worse the longer you leave them untreated. How are you going to diagnose this? You would do a complete blood count, and I didn't put up the mean corpuscular volume here, but that would be indicative of a confirmation of aplastic anemia. Okay. We would look at iron levels. We're looking at leukocytes, thrombocyte levels, erythrocyte levels. So we're looking at multiple features from the complete blood count. Right? Now, bone marrow biopsy, again, that's going to be a fairly invasive procedure, but there you're going to be collecting a sample of bone marrow and looking at the cells. Okay. For treatment, now this treatment can really be applied across the board, oxygen therapy. So you're trying to load up the hemoglobin with oxygen, okay. Hemopoietic stimulation, so maybe just the colony cells need to be stimulated a little bit with growth factors to increase the production of blood cells. You are going to take preventative measures towards developing infection, right? You're actually going to try to reduce the infectious rate happening to an individual like that because they are immunocompromised. On the other hand, if it's due to autoimmunity, we're going to see that you might want to suppress the immune system, right? You might give blood transfusions and then transplants, right, which would bring us back to the problems associated with transplant rejections and getting the correct blood type. Okay. All right, so hemolytic anemia. Hemolytic anemia is going to be excessive destruction of the red blood cells. Now, we've already covered a couple cases, really, of this, and we talked about blood transfusions. Okay. When blood transfusions, the wrong blood type has been infused in our body, our immune cells detect this as foreign, and they start destroying those red blood cells. And so that's what hemolytic anemia is when there's just too much destruction, right? But in this case, it's a healthy version, right? So in our body, in that the red blood cells are being destroyed too fast. So causes of hemolytic anemia, we have inherited and acquired causes. And so inherited causes can include autoimmune, right? So if your antibodies are detecting your red blood cells as foreign, okay, it's going to target them and destroy them. Or if you are passed down a genetic condition in which your hemoglobin or red blood cells do not form correctly, or we see some other defect in those cells. This is versus acquired, right, where this can be due to viruses, idiopathic, mismatched blood transfusions, and erythroblastosis fetalis, otherwise known as hemolytic disease of the newborn. Okay, and so we see a few different ways that they could really occur in our body. So the different types of hemolytic anemia. Now for this lecture, we're going to focus on sickle cell anemia. Okay. But there are various other types, like I just mentioned. So we have thalassemia, okay, and erythroblastosis fetalis. So we're going to focus on these, really these two. We're not going to focus too much down here. We've already talked about it. But it's, remember, this is HDN, hemolytic disease of the newborn. So the child's red blood cells are essentially going to be attacked by the mom's antibodies because previously in a previous, so this is for Rh negative moms only and Rh positive babies or fetuses, and so the mom's blood has been exposed to the fetus's blood, which leads to the development of the antibodies. And so if that mom ever sees the fetus blood with an Rh positive group again, she's going to essentially produce the antibodies that need to be triggered, and then those antibodies would cross the placenta, and then they can go and start acting on those cells that they are detecting as foreign. Okay. So we see that sickle cell anemia, okay, is generally genetically transferred. Okay. And one thing about sickle cell anemia is thought to co-evolve as a response to malaria. And so you see that individuals with sickle cell anemia don't get sick with malaria either as frequent or at all. We see that sickle cell anemia is a co-dominant trait, so the mutated form of this is dominant, but also so is the normal form, the alpha and beta hemoglobin types. Okay. So we have two different hemoglobin. Okay. We have hemoglobin S and we have hemoglobin A, and so this hemoglobin S, would be considered heterozygous because we have two different alleles coding for really the same trait. And normally we would have, for type A, we would have hemoglobin A. If we are AB, we would have hemoglobin B and hemoglobin A. Okay. And if we don't have any hemoglobin, we wouldn't have an allele for a glycoprotein that is expressed on our red blood cells. And so these individuals don't actually have anemia because this hemoglobin A is able to produce enough hemoglobin A in normal red blood cells for normal function. Now, this one down here, the homozygous sickle cell hemoglobin S, and then it's paired with a hemoglobin S. This gives severe sickle cell disease, right? So where the cells take on the sickle shape. So a sickle is a curved structure used for cutting wheat. And so the red blood cells will take on this kind of characteristic appearance of sickle cell anemia. Okay. So the issue with the red blood cells are still small, so they should be able to flow through circulation. But the problem here is they can get wedged and lodged into capillary beds, especially when they branch off. And so we see that the capillaries of red blood cells lodge into capillary beds and small arteries and veins, and this causes a tremendous amount of pain in the individuals with SCD. Okay, so the problem with sickle cell anemia, in addition to the pain, okay, is you are transporting less oxygen, right? So now the red blood cells don't actually take on their characteristic shape. So this binucleate, sort of this oval disc with a little indentation that really promotes loading the hemoglobin with oxygen. Okay, so now they have this inability to carry as much oxygen. And you see this disorder more commonly from people with African or Mediterranean descent. It is also present in other cultures and ethnicities of the world, so Central and South America, Caribbean, Middle East. And so we see a higher rate of incidence among individuals from these parts of the country. Okay. Manifestations of sickle cell disease, they are going to appear in the first 4 months of life. And so you can see that sickle cell events, so this is an event, and so you're not always suffering from sickle cell disease. You can see episodes of sickle cell anemia present. Okay? Sickle cell disease start to present, and so these episodes can last for hours to days. Okay? The pain that is caused by sickle cell anemia or sickle cell disease is caused by decreased blood flow to tissues. Right? Anytime you have decreased blood flow to tissues, right, you see a reduction in ATP production. Well, if you can't maintain that ATP, then tissues start to die. Okay? And so we can see that sickle cell disease is stimulated by a number of factors: dehydration, stress, high altitudes, even fever, right? So all these are considered stress. The pain is caused by ischemia or necrosis, and the events can last for hours to days. They are not suffering from sickle cell disease for years. These are relatively short bouts of time. Specific manifestations that we're going to be looking for. abdominal pain, bone pain, labored breathing, that's going to go with anemia in general. Delayed growth and development is going to go hand in hand with the ability to transport oxygen and build ATP. Fatigue, you're going to be tired. Fever. Okay, now we have a bunch of other manifestations like jaundice. Jaundice is the yellowing of skin, okay, due to the hemoglobin or the red blood cell breakdown, right? So during normal red blood cell breakdown, we break down hemoglobin into bilirubin. We send it to the spleen to be processed. Okay, and so an individual with high rates of erythrocyte destruction, okay, which is being caused by the sickle cell disease because the cells are being wedged into capillary beds or small arteries, and then they start to break down, right? So then we really start to target them. Okay? And so the increased concentration of bilirubin, which is the byproduct of hemoglobin breakdown, results in this yellow coloring of the skin. This could also be due to liver failure or liver disease. Pallor, right? So the loss of coloration to the skin. Tachycardia, because now you're going to be trying to move the blood faster through the circulatory system to load it with oxygen. Tachycardia. Skin ulcers. Angina. Well, the skin ulcers would start to develop because now you are lacking the ability to repair things. Angina can happen, and we'll talk more about angina when we get to the heart and to the cardiovascular system. Excessive thirst and frequent urination. Priapism. Priapism is the persistent and painful erection of the penis. Okay. And then vision impairment. So anytime you have circulatory issues, the eyes would be one of the main effects. So you see that diabetes can cause blindness. Okay. And this is due to the effects on the circulation. Okay, so how would you diagnose sickle cell disease? Sickle cell disease is diagnosed by, first and foremost, performing a complete blood count. Okay. And then if you're getting some results there that are kind of skeptical, then you would do a follow-up with a hemoglobin electrophoresis and the bilirubin test. So the electrophoresis lets you look at the different sizes of the hemoglobins to detect if you have a hemoglobin the size of the sickle cell disease form. And then a bilirubin test would give you a direct measure of how those red blood cells are doing in circulation, and specifically if they're being broken down and you're getting hemoglobin breakdown into bilirubin, right? So if those bilirubin levels are high, then you might expect the positive confirmation of sickle cell disease. Now, there is no cure for sickle cell disease. However, life expectancy is beginning to improve. So again, no cure. Now, why don't we just target the bone marrow cells and tell them to stop producing the sickle cell disease form? That is an area of promising potential. However, when dealing with stem cells, you're always dealing with moral issues. Okay? We could give medications and then avoid triggers that would really start this process. Okay, other strategies can include oxygen therapy, hydration, pain management, infection, vaccination, blood transfusions, bone marrow transplants, and genetic counseling for to-be parents who know they have the sickle cell disease, and if they want to go talk to a counselor about their chances of having a child. So the vaccinations are going to be a part because your immune system is going to be slightly compromised, and so if you have vaccinations, you already have the antibodies there for taking care of things that are new to your system. Some additional complications of sickle cell disease. On the bone, we get osteomyelitis, which is an infection of the bone, essentially. The kidney, we can see hematuria, which is blood in the urine. tubular concentrating effect, so now our renal tubules might not concentrate urine as effectively as they would. We see issues in the eye, like I said, blindness and retinopathy. Okay. Spleen, if we're releasing some of these products back into circulation, you can see the stroke occur. Hyposplenism. Okay. Now your spleen is just going to be overworked, so your susceptibility to infection might increase because now your spleen is doing all this other work. And then the liver, we're going to see jaundice and then hepatomegaly results. So hepatomegaly is enlargement of the liver. Jaundice is obviously from the breakdown of bilirubin. Now moving on into thalassemia. Thalassemia is a type of anemia, so this is going to be a hemolytic anemia. And so what we get is we get abnormal alpha and beta chains that comprise our hemoglobin molecule, okay, our hemoglobin protein. So this is an autosomal dominant inheritance pattern that we see going on here. So only one parent has to have a copy. We see most of the time that this disorder is most frequent in individuals with Mediterranean descent, Asian, Indian, and African descent as well. What is it? Thalassemia, since you are producing those two irregular hemoglobins, we see that it results in that cell death, and so this hemolytic anemia increases, so your breakdown of the red blood cells, but also your ability to transport oxygen because you have these abnormal alpha and beta chains. Okay. So life expectancy is improving, but it is a fairly serious condition. So what are the manifestations? For a pregnant woman, abortion is going to be one of the manifestations. If they don't have the oxygen carrying capacity to support a fetus, then they will abort that fetus. If you have this as a child, okay, you are going to experience delayed growth and development, and this can include mental retardation, fatigue. Okay, should always be pretty much assumption when we're talking about any form of anemia. Dyspnea, so labored breathing, heart failure, hepatomegaly, splenomegaly. Okay, and those are both going to go with the increased destruction of red blood cells. Bone deformities, so if we don't have enough oxygen to facilitate any of these processes, okay, and then jaundice is going to result from the increased erythrocyte breakdown. Okay. So how do we diagnose this? We're going to be looking at a complete blood count, again looking at mean corpuscular volume. We would look at iron levels, we would look at erythrocyte counts, and then we would also include in there mean corpuscular hemoglobin content. And so we're going to see that this mean corpuscular hemoglobin content has a lower amount of hemoglobin compared to normal, and we're going to have a low mean corpuscular cell volume. Okay. How would you treat this disorder? Blood transfusion, chelation therapy can be where we're pulling out things out of the blood that normally cause this lysis, and then a splenectomy. Okay, so a splenectomy isn't really totally curing it, except we are sending those cells to the spleen to be destroyed because they're being detected as abnormal. All right. So our last condition of erythrocytes that we're going to talk about is called polycythemia. Polycythemia is a disorder in which erythrocytes are produced in too high of a quantity, and so now it's not a problem of lack of oxygen, but now it's going to present an issue regarding the cardiovascular system. Okay. And so this is going to be a high amount of erythrocytes. It's rare. It's pretty much only found in men. we see it being a neoplastic disorder because of the uncontrolled proliferation of erythrocytes that we see here. Okay. And so what can happen is blood vessels actually begin to distend, which means stretch, okay, due to the increased blood volume. Okay? So increased blood volume and blood viscosity that is a result of increased numbers of red blood cells. The increased red blood cells leads to tissue ischemia and necrosis. Okay? So as viscosity increases, blood pressure will increase. As blood volume increases, blood pressure increases. Okay. So some complications of this disorder can include the tissue ischemia and necrosis, thrombosis. So as blood flow starts to move slower, it gives time for clotting factors to come into the same area and initiate the clotting cascade. Hypertension due to the elevated blood volume and elevated blood viscosity that we see up here. Heart failure can result, so if it becomes too much for the heart, obviously the heart would stop contracting in a unified manner. Hemorrhage, splenomegaly, so the increase, sort of the enlargement of the spleen, enlargement of the liver, okay, and then acute myoblastic leukemia can also complicate this issue further, right? So acute myeloblastic leukemia is going to look at those stem cell precursors, or there's colony forming cells, colony forming units as otherwise known. And so we can see some cancer of the myoblastic cells. Okay, so what are the manifestations for polycythemia? All these could be manifestations of polycythemia. So cyanotic or plethoric skin. So this is referring to skin color, either blue or red. And so this could be due to oxygenation status of the polycythemia. Either it's not being oxygenated enough because there's too many red blood cells, and they are slowing down the process, or we have fine oxygenation patterns, and we are showing it because now we have too many red blood cells. We can see high blood pressure as a result of high blood volume, and then elevated blood viscosity. Okay. Again, so as blood starts to slow down because maybe there's too much viscosity, we could see a tachycardia result, right? So now you want to circulate this blood more to make sure that oxygen patterns are being maintained and oxygen delivery to tissues is being maintained. Dyspnea, because now we're going to have some issues with loading up hemoglobin with oxygen. Okay, so this is labored breathing. And then anytime you have really deficiency in oxygenation status in the hemoglobin, we're going to get some neural things, and so headaches or visual abnormalities might result. So how do you diagnose polycythemia? Complete blood counts would be your go-to first response to get an idea of what exactly is going on. And so the complete blood count would tell you that now we have an increase number of circulating erythrocytes. So you have erythrocyte counts. You would likely want to look at the bone marrow to see what the cells are doing, and since this is considered a neoplastic growth, you would want to take a survey of what is going on inside the bone marrow. And then uric acid levels. So uric acid is produced when cells turn over, and we can oftentimes get the development of a condition called gout, and this is going to be when uric acid crystals actually form in circulation, and they generally occur in joints, and so it can make it very painful to walk. And treating polycythemia is going to take two standard cancer treatments, so chemotherapy and radiation therapy, to try to either knock down or remove the dysfunctional cell. Okay. Phlebotomy would be removal of blood, and then we have manage clotting disorders. So as you recall, during polycythemia, we get slowing down of the blood, and so this gives clotting proteins more of an opportunity to become concentrated in a little area, and so we would want to remove the clotting proteins and prevent them from acting. So, well, that's it for disorders of red blood cells. Until next time.